Tarik, we are live, right?
You are live now, sir.
So good evening, everyone. So welcome to another episode of DOS Super Tuesday webinar series. And in that series, this is cornea surgery learning course, and you have been taught about PKP, DMEC, DALK. These are all super specialized surgeries in corneal surgery. Today we have a basic surgery that you most of us have to do it, and importantly residents have to do it in emergency, which is corneal tear repair. And for that we have an excellent speaker, rather somebody whom you all know through different weight lab training program, and she has been teaching you how to do this over the last few years. And today we are lucky that she has agreed to take this lecture on a very short notice. So welcome Dr. Pranita Sahai, and Dr. Pranita is currently assistant professor at RK Center AIMS New Delhi, and she has previously worked at Guru Nanak as well as UCMS. And her academic credential include multiple degrees like FRC Opt, FRC Glasgow, FICO, and more than 150 PubMed Index publications with two books. And recently she has even launched two new books for postgraduates as well as one on cornea master classes. So Dr. Pandita, welcome, and let's begin with your lecture.
Thank you so much, sir, for that kind introduction. So, my talk for today is going to be on the management of corneal tears, corneal perforations, and even corneoscleral perforations that we'll be covering. So, as we all know, that the setting of injury can be at any place. It can be during the daily activities, road traffic accident, sports injuries, assaults, agricultural areas, or industrial areas. So, it is very important that whenever you're taking a history, a detailed history must be taken up, because all of this has a lot of medical legal implications, because any injury at their workplace is going to be a medical legal case, for which later on compensations can be filed, and hence a proper documentation of the trauma, the nature of injury, the time, place, and everything should be recorded very much in detail and in precise. So, traumatic perforations, as you all know, can be open globe injury, can be either an occult scleral perf or corneoscleral perf, or a complete limbus to limbus corneal perforation. The site of injury in blunt injury is usually circumferential and is behind the ocular muscles or can be adjacent to the optic nerve, while open globe injuries, usually from a sharp object, tends to cause direct corneal perforations. So when you're doing a workup of these patients, it's just not that the surgery which is important, but the baseline evaluation of these patients should be done in a lot of detailed workup needs to be done, wherein a basic visual acuity assessment, a slit lamp assessment for the extent of perforation and the other associated injuries needs to be documented, a Seidel test to look whether it's a full thickness perforation or it's a lamellar perf. A fundus evaluation, if the media is clear, is also essential, and if the fundus is not visible, an ultrasound is almost always mandatory before you take these patients up for surgery, because they may have associated vitreous hemorrhage, retinal detachment, choroidal detachment, and since these are potential medical legal cases, a proper documentation at the baseline is very important. And most of these traumas, sometimes you can have injury with a glass or a stone or an iron particle. Hence, an X-ray and a CT scan becomes important to rule out presence of intraocular foreign bodies. Well, metallic foreign bodies will be picked up on X-rays, but if you have an injury with a glass, even an X-ray can miss these foreign bodies, and in such situations, a CT scan would be essential to rule out the presence of any intraocular foreign body. Now, the general principles of management, what is the primary aim? The primary aim of any open globe injury is to achieve an anatomical integrity, that is to close the open area, to suture it and close it up, because it's any open wound, as you know, is a potential source for infection, and hence you need to achieve a good anatomical integrity, and that is the primary target for any open globe injury, while the secondary target is that you achieve a good functional outcome and a good anatomical restoration as well. So, vision, whenever a patient is coming with trauma, their primary concern is whether I'll get vision or not. But you should always explain that the primary aim right now is to close the wound and achieve a good anatomical integrity. And to achieve a good vision is something that you will be able to predict only later on. Now, since these cases, as we already discussed, are potential medical legal cases, hence a documentation of the mode of injury, workplace assault, and the type of injury, whether it's a simple injury or a grievous injury, and consent, wherein a detailed prognosis, visual prognosis, need for repeat intervention, and risk of infection, everything is explained to the patient pre-operatively, can make the post-operative course really easy for you, because the baseline counseling is something which is very essential, and you should at least give 5 to 10 minutes of time to every patient before you take them up for surgery. Now, there are a lot of classification systems. You have the ocular trauma classification, the BETS classification, and these classification systems are important because they help in prognosticating the patient. Now, this is important for theory purpose because in exams, these zones and grades of injury are often asked. So for closed globe injury, it can be either a contusion, lamellar laceration, superficial foreign body, or mixed. You can also grade them based on the visual acuity, the zone of injury. Anything extending up to the limbus is zone 1, and going beyond the limbus goes into zone 2. 5 millimeter behind the limbus is zone 2, and anything going beyond 5 millimeter behind the limbus is zone 3. So that these zones are different for a closed and open globe. For closed globe involving the bulbar conjunctiva and sclera and cornea are zone 1, whereas any injury extending up to the pars pliccata is zone 2, and that extending in the posterior segment is zone 3. So going on to the prognosis. So any patient that you're taking up for surgery, again, it is important that you give an ocular trauma score. So it is based on these 6 factors, that is the baseline visual acuity, presence of globe rupture, end of perforating injury, retinal detachment, and RAPD. On the basis of this, a total score is given, and on the basis of the final score, you can prognosticate what is going what is their long-term visual outcome going to be like, what is the probability that the patient will end up with a 612 vision or a no PL or a hand movement, is based on the raw score that you have calculated initially. So now moving on to the surgical principles, general principles of a corneal perforation repair. So what is most important is that you first identify the anatomy, that is the limbus. So any perforation that is extending up to the limbus, the first identification of the limbus and suturing of the limbus is important, and then you move on to suturing the central part of the corneal perf. Every suture should be at least 80% depth, equal in length on either side, and the suture length should be long in the periphery and short in the center to reduce less scarring in the center, less astigmatism, and get a good visual outcome. So this is a diagrammatic representation of how your needle track should enter. We'll see a lot of videos in the subsequent slides, but to begin with, it is important that you understand how your suturing should be like when you're repairing a corneal perf. So most of the corneal perforations are repaired with the 10-0 monofilament suture, and this is how you enter. So you enter with your needle track vertically, and once you have achieved an 80% depth, you turn the track of this needle and curve it around so that you can take the next turn out, coming on the opposite edge or the other side of the perforation. So enter vertically and then take a curve and then come out vertically. That's the basic principle that you need to remember. And equal length on either side of your wound is important. And this important law that all your sutures near the limbus have to be long and the ones towards the center have to be short. So these are some of the basic principles. If you follow, you will achieve a good anatomical restoration and a good contour of the cornea, which is our primary target. You don't want to flatten too much. You don't want to steepen too much. So the peripheral sutures, you begin always with the suturing in the periphery. Once you suture in the periphery, your central, you are flattening the peripheral cornea and steepening the central cornea, and then you move on to suturing in the center, and it's always easy if you follow this pattern. Now, as we already discussed, equal lengths on either side is important, because if you have a shorter suture track on one side and a longer one on the other side, when you tighten the suture, the tissue is going to override onto the other side where the suture tract is short, and this will lead to a shelving and poor apposition and poor slow or a poor healing, and even sometimes if there is too much of overriding, your tissue may melt and not heal at all. Sometimes the defect or the perforation may not be absolutely perpendicular. You may have an oblique or a shelving kind of an injury. So now again, what is important is at the point where you are suturing, that is the 80% depth. At that point, your distribution of the suture length should be equal on the either side. For example, here, if you consider the topmost part and you try and keep the suture length equal on either side by looking at the topmost surface, then you may end up again with an improper apposition or shelving post-operatively. So you have to look at as to what is the posterior edge of your wound like, and then divide your suture into equal lengths considering the posterior aspect as well. Now, it is important that you always bury every suture, because the knots kept on the surface, your mucus and debris is going to collect, and it's always going to be a source of infection and severe inflammation because of the knot causing ending up into a giant papillary conjunctivitis in these patients. And don't always, whenever you're burying, ensure that your knots are away from your visual axis and they do not get engaged into the wound or the perforation site, because then later on when you try to remove the suture, if the knot is engaged into your perforation site, it will be difficult. The sutures may tend to get broken, and you may have retained fragments of sutures left behind in the cornea. So avoid burying it onto the visual axis and avoid getting this engaged into your perforation site. Now let's look into some of the videos. So now this is a patient of a clean-cut case of a corneal perforation. You have a small perforation here right at the center. Although this is not a linear perf, it is a curvilinear kind of a perforation. So what do? First, we make a side port entry, inject air, and inject adrenaline. Now, since the chamber is very stable, you can suture under air as well. Now, important, every suture has to be absolutely perpendicular to your site of perforation or the perforation tract. So here, because the perforation was curved, hence you can see that the two sutures that we have put are oblique. They are not parallel to each other, because the target here is to achieve a suture which is absolutely perpendicular to your perforation tract. So don't try and achieve sutures which are parallel to each other, but sutures which are absolutely perpendicular to your wound tract. So you see, we tried to achieve an equal length of the sutures on either side of the wound. We achieved a perpendicular suture to this wound that you are seeing, which is a curvilinear fashion, and the suture knot was ultimately buried. Now let's look into some more complex situations. Now this is a patient of a globe rupture. There was a firecracker injury and a patient ended up in a very bad perforation. So here, what are we doing? The first suture, as we all discussed, has to be with the 10-0 monofilament at the limbus. So at the limbus, both the sides of the limbus was sutured with the 10-0 monofilament. Then a side port entry was made, and following which air was injected. And since this was a very bad perforation, so in this viscoelastic was injected to ultimately repair. So after the two limbal sutures, a central corneal suturing was done, and now the corneal perforation was divided into two equal halves, which was subsequently repaired by interrupted suturing with 10-0 monofilament. And what is again, now this patient also had a scleral perforation. So we did a localized peritomy in the area where the limbal suturing was done. And then you can see the scleral perf is being repaired with the 6-0 Vicryl sutures. And here, what all you need to achieve is a good apposition. Don't tighten the suture too much. If there is any uveal tissue incarcerated, uveal tissue may be excised depending upon whether it's a fresh perforation or it's an old. If it is presenting within 24 hours, usually we do not tend to excise the uveal tissue. However, if it is more than 24 hours, it is better to excise the uveal tissue and then continue with the suturing. And since these patients are always at risk of infections and end off, it is always important that you also close your side port with the 10-0 monofilament so that you have a watertight compartment and there is no risk of leak and infections in these patients. Now, sometimes you can have a perforation like this. It's a cornea. This patient had a corneoscleral perf extending 5 millimeter into the cornea and 5 millimeter behind the limbus, extending up to the zone 2 of the sclera. So how do you go about repairing? So primarily what is recommended is that you better repair the cornea first and then go on to repair the sclera. However, in this patient, the AC was formed and the corneal wound was quite well opposed. Hence, first, after achieving the limbal suturing that was done with a 10-0 monofilament suture, a localized peritomy and good exposure of your scleral perforation was done. And here you can see the uveal tissue is visible as the bluish hue. So you also need to ensure that all the tenons around this perforation site is also retracted as much as possible so that the suturing becomes easy. And when you're suturing, avoid taking the needle through and through both the edges of your perforation, because in such a situation, you may tend to engage your uveal tissue. So always be sure you are avoiding the uveal tissue from being incarcerated in your needle track. And here with the cotton wick, you can see with the Merocel wick, we were checking for a vitreous tissue prolapse. And since if there was a vitreous tissue prolapse in this patient here, it was gently cut with a Vanna scissor, ensuring that the vitreous does not get incarcerated into the scleral perf that was repaired. And always the suturing in your scleral perforation, you start from the limbus and step by step you move posteriorly. And sometimes if the extent is too posterior, you can leave a long knot or a long thread of one of the vical suture that can help you as a traction point to retract the globe and help in further suturing on the posterior edge of the scleral perf. Now here the corneal perf is now being repaired. An MVR entry was made, air and pilocarpine was injected, and this membrane present over the iris tissue was excised. Since this was a fresh perforation, patient had presented within 24 hours. The iris tissue was not excised. In fact, it was reposited. And you can see now 10-0 monofilament, 80% depth of suture was being achieved. We entered vertically and took a curve and came out and completed the suturing. Now the gap that was present was also sutured with the 10-0 sutures. The sutures toward the central cornea were kept short. And it always in the first suturing, it may not be possible to achieve perfect apposition. Sometimes sutures tend to get loose as you complete your closure. So you can always replace your sutures if there are any tight or loose sutures. And after completing the corneal perforation repair, here the conjunctiva is being closed with a 8-0 vicryl suture. With an interrupted suturing is being done. And with this, side port suture was also closed and the case was completed. Now, this is a triradiate perf. Always, you may not have a perforation which is going to be absolutely linear or for you to deal with easily. So this was a triradiate perf. Again, it was a case of a firecracker injury. So MVR entry, air, pylo, and viscoelastic was injected. So here what you need to do is just take the edge of the triangle of the triradiate and suture it up. If you suture that, you are going to convert this triradiate perf into 3 linear perforations, which you can then repair easily with interrupted suturing. So it is the edge of the triradiate perf that needs to be tackled first. This wedge was first tackled with an interrupted suture, and then these 3 perforations, it was converted to 3 linear tracts, which was then repaired with a simple suturing technique that we routinely do. After this, a VSS wash and air was injected. Since there was mild leak from the center, you can always use a tissue adhesive, a cyanoacrylate glue. Backup can be kept in these cases. Avoid too much tight suturing because that can cause distortion of your cornea and end up in a lot of astigmatism. So if there is a small defective tissue or a focal leak, you can use a cyanoacrylate glue as a backup. However, if there's a large tissue defect, it is better to refer the case to a cornea specialist who can convert this patient and do it into a corneal patch graft rather than doing too much of distortion by suturing it with a tight suture. Now, sometimes you may have a combination of all these injuries. So here, this patient had a corneoscleral perf, and the injury was extending from one limbus to the other limbus, but it was not a linear one. You see, a lot of ragged edges were present. Along with that, there were two triradiate perf. Here, you can see there's another triangle that is forming in, and this is a second triangle that was forming in. So you need to use a combination of all the techniques that we have discussed till now. So here you see, first and foremost thing is that you have a good exposure and you assess the extent of your perforation that you're dealing with. So here again at 11 o'clock position where we were expecting a scleral perf, we did a localized peritomy and saw that the scleral perf was extending to almost just 1 to 2 millimeter, not too much posterior extension was noted. And first and foremost what we achieved was the limbal anatomy restoration with the 10-0 monofilament suture. So here the limbus is restored, and then we made, because the chamber was completely collapsed, we did make an MVR entry, and air, pylo, and viscoelastic was injected as has been shown in the previous cases. And after this, the other end of the perforation was tackled again with the suturing. So the edges were first dealt with. After this, these notches that you saw, so there were a lot of notches that were forming. These notches were first sutured so that rather than having a zigzag kind of a repair, we converted the zigzag repair into 3 linear repairs. So we divided into, we put end-to-end sutures on the limbus. Then we made a suturing here where there was one angle forming. There was another angle forming here on this point, which was sutured, and it was divided into 1, 2, and 3. So it was divided into 3 parts, which was then sutured. But before we went on to suturing those 3 linear sutures, we also had a triradiate perforation to deal with. So as we had discussed, first at the wedge or the triangle edge, a suture is passed, and a long suture, long bite needs to be taken up here because the tissue is often very friable, thin, and it can cheese wire very easily. So take long bites at this point of time and try and suture it in one go, because the tissue is so friable that you may not be able to pass the needle more than once. And if you try to do that more than once, the tissue will cheese wire and you will lose that opportunity to achieve a good apposition with your corneal suturing. So here we almost had a crisscross suturing, and after which things became easy because we now just had the linear perforation, linear corneal tears, which had to be managed with interrupted 10-0 suturing, which is central sutures being short and the peripheral suturing being long. Now, after the corneal perforation repair was done, the sclera was sutured with 6-0 vicryl, and the overlying conjunctiva was closed with 8-0 vicryl. A BSS wash was done, and the size of the air bubble, always remember to reduce the size of the air bubble in these patients because the patients are phakic. You can end up in a pupillary block. And also, if your wound apposition is not good, you may not be able to appreciate the sedals because the air bubble is going to mask the presence of your wound leak or sedals. So here what we did is we reduced the size of the air bubble, and with the Merosil sponge we checked for the leaks, and once we were sure that there is no leakage, that is when we closed the case. So this is how the patient looked post-operatively. A lot of sutures, but yes, we achieved a good anatomical integrity. You are seeing what the law, as per the law, the sutures in the periphery here were being long, and the ones in the center short to induce less astigmatism and less scarring in the visual axis. And we tackled this triradiate perf and another triradiate perf and limbus to limbus corneal perf, although it took almost 1 to 1.5 hours, but it was managed well. And a very important thing is to plan the anesthesia in these patients, whether to take these patients up in local anesthesia or to plan these up in general anesthesia. So whenever your injury is massive, or you have a large perforation to repair, and even a large corneal limbus to limbus perforation, it is always preferable to take these patients up in general anesthesia, so that you have minimal upthrust, and good cooperation is what is needed from the patient. And sometimes the patient are in so much of pain, if they squeeze, it's almost impossible to achieve a good outcome in these patients without a general anesthesia. However, if it's a small perforation, they can be taken up even in a subtenon block. A short note on how to do a scleral perf repair. So in this, we have already seen a localized peritomy to achieve a good exposure of the scleral wound, and then closing the limbus first, and then move posteriorly from the limbus to close till the posterior extent as much as possible. If there is any prolapsed vitreous, it needs to be excised. Prolapsed uveal tissue, reposit if it's fresh and looking healthy, excise if it's a late presentation or suspected infection, and close from the limbus and move posteriorly. In case if your perforation is extending beyond the recti, you can disinsert the muscle, repair the perforation, and reinsert the muscle. And if there's a tissue defect, a patch graft may be required. Cryotherapy at the site of scleral perforation previously was propagated, but now all the retina specialists do not propagate the use of cryotherapy or a prophylactic cryotherapy, because that itself induces a lot of inflammation and PVR changes and can cause retinal detachments per se. So now this is a patient who came with a blunt ocular injury, and you can see there was just a mild subconch hemorrhage and this bluish hue. Whenever you see something like this, even the patient had a 6/6 vision and an IOP of 12, but it was a case of an occult scleral perf. It is always better to explore and repair. Preoperative fundus evaluation was showing a focal area of bleed here, and hence we took this patient up for scleral perforation repair. And this patient, you can see a localized peritomy is being done so that you can expose the area of the perforation well, and also remove the tenon tissue so that you can achieve a good suturing. So the principle remains the same. Almost more than 50% depth of your scleral tissue needs to be engaged with this suture. And when you're passing, the needle should be visible to you when you're passing on to the opposite edge. Ensure there is no uveal tissue getting incarcerated into this, because how good a repair that you're going to do is going to finally decide the patient's outcome. If there is uveal tissue or vitreous incarcerated, it is the patient will end up in a retinal detachment. So how well do you repair the scleral perf is going to decide the patient's final destiny. Then the overlying conjunctiva is again closed with a 6/0 vicryl, 8/0 vicryl, and this is how the patient looked post-operatively. Now, the post-operative management in these patients include a topical antibiotic and a topical steroids, topical cycloplegic and topical antiglaucoma, oral antibiotic, oral steroids if you are manipulating with the iris tissue a lot, or if you have excised the uveal tissue, or it's a case of a scleral perf. In all such cases, oral steroids should be prescribed, but you have to be sure that there is no infection in these patients before you go on to prescribing these steroids. Oral NSAIDs, because the patient is in a lot of pain, and you can give a short course of oral NSAIDs as well to these patients. And so coming to the complications at the wound site, what are the complications that you can see? You can see a wound leak on the first post-operative day. If there is no bandage contact lens, it's always a good practice that you put in a drop of fluorescein and stain and look for any leakage. If there's a leak, there's no harm in taking the patient back to the OR and repairing it further rather than ending up in a complication later. Sometimes your conjunctiva can get retracted. You can have sutured site infiltrates or a vitreous prolapse in your wound, or your iris may get incarcerated into the corneal wound repair, and that will again have to be dealt with by taking the patient back to the operation theater and repositing the iris back. You do not want any iris to be present on your surface of the wound that you have repaired, because it is not just this eye that you are managing. The fate of the other eye is also dependent upon how good a repair and how good medical therapy you give to the injured eye, because there's always a risk of sympathetic ophthalmitis if you leave any uveal tissue exposed onto the surface or if you manipulate too much. The posterior segment complications include endophthalmitis, vitreous hemorrhage, choroidal rupture, traumatic uveitis, and choroidal detachment. And hence, all patients of perforation repair should get a retina consult in the immediate post-op if the fundus is visible. And if the fundus is not visible, close follow-up with serial ultrasound should be done to look into these complications, which needs to be managed as soon as possible. Sometimes these patients can end up in infections like endophthalmitis and panophthalmitis. And looking at the other eye at every follow-up is also very important, because sometimes these eyes are so badly injured that the visual prognosis in this eye is going to be bad, but the other eye needs to be taken care of for the rest of their lives. So document the distance vision, near vision, and explain the signs and symptoms of sympathetic ophthalmitis, blurred vision, any blurring of near vision. All these things needs to be explained to the patient when they're getting a discharge or when they're coming for a follow-up. And phthisis, whenever you're operating a patient of a globe rupture, extensive injury, phthisis is something which can happen, and it is very disheartening for the patient. But if you properly counsel them in the preoperative phase, if this outcome does happen to the patient, they are not going to blame you that it is because of the surgery that it has happened, but it was a possible outcome of the trauma that they had. So the take-home message is that you should have a detailed history and clinical examination in these patients and a proper documentation, a meticulous surgery by a proper exposure of the wound and opposing the anatomical landmarks and avoiding any vitreous loss, and repairing from the limbus posteriorly for scleral perf and for corneal perf, starting from the limbus and moving towards the center. And a careful and a close follow-up in these patients to look at these complications and to manage them whenever they occur. So with that, I will conclude this class. And we also have a short video
We
from...
can play that later, Dr. Pranita.
Yes, sir.
Sharik, if there are any questions, please share with me. So thank you so much for that wonderful lecture. And I think one point that Dr. Pranita highlighted is very important for students or delegates who are here. So you have to remember anatomical landmarks. Okay. So what is an anatomical landmarks? To begin with, it's limbus. The second is all those junctions which Dr. Pranita showed you in that video. Any angulated points where there is an angle forming, that is your next anatomical landmarks. So when you are starting suturing, the first goal is to put suture in these anatomical landmarks like limbus, or if it is a right angle tear, exactly at the angle. So first suture should be placed there. And second thing, as she rightly highlighted, how would you know that your suturing is adequate, right? And for that, you have to remember one thing. If your length of the suture is 2 mm, just whatever part is above the tear, for example, 1 mm, if it is a equidistant suture, then the force or the strength or the tectonic stability will extend 1 mm on either side of the suture. Okay, so that's how you decide how many sutures you want to put. Because we have seen, because we are a referral center, we get a lot of patients repaired perf, and for a perforation extending 5 mm, you can see 10, 12 sutures are there. So that is unnecessary, that leads to abnormal healing and abnormal scarring. So remember this concept, whatever the length of the suture is, 50% of that is going to the area that will be covered by that particular suture. So if you put long suture, you need less suture. If you put short suture, you need more sutures. That is the basic principle that you people should remember. And second important thing that Dr. Pranita highlighted is if you have a corneoscleral perf, then how to go about that. And I think the basic principles she has rightly highlighted. First, you suture the limbus, and then on the anatomical landmarks, and then form the chamber, and then decide whether you are going to suture the cornea first or the sclera first. By default, we repair cornea first, but there is another view also. Few people, after putting the anatomical landmark suture, they repair the sclera also. So that is also a possible thing that you people can do. One query, probably most of the time, Dr. Pandita, which a lot of time people do error while judging is whether to touch the lens matter or not. So could you just elaborate on that? If there is a ruptured capsule, so how to proceed about whether the lens should be removed on the first, same setting, or you should wait? And what are the logistic factors that will decide whether you are going for a primary IOL or a secondary IOL implantation?
Yes, sir. So I think a lot of patients with an open globe injury, they also have a lens rupture. But what we need to look into is what is the extent of rupture and how much of a cortical matter or a lens matter has prolapsed into the anterior chamber, and how much inflammation is it really causing. Always doing a second stage cataract surgery, I find it leads to better outcomes in these patients. But we need to look into, if there's a lot of lens matter in the AC, then we may have to tackle the lens in the same sitting as well. However, if there is just a focal rupture, focal breach with minimal lens matter in the anterior chamber, we may just wait and watch for 2 to 3 weeks, give intensive steroids, and once the capsule has fibrosed, then we may be able to achieve a good rhexis and be able to deliver a better outcome by doing a cataract and an IOL implantation in these patients. So I think if there is a lot of lens matter in the AC, it's a large rupture of the lens capsule and severe inflammation or severe uveitis that you're seeing because of the ruptured lens capsule, then I would like to touch the lens, or else I would like to just wait for 2 to 3 weeks and do a second stage cataract surgery. Even if possible, we can wait for 4 to 6 weeks. In that meantime, your sutures can be out and you can get a good keratometry value, and you can do a proper IOL power calculation in these patients. And as sir rightly highlighted, the logistic issues, IOL may not always be available. You may not have an IOL library immediately available, or a multi-piece IOL may not be available in such patients. Sometimes you may have a PC rupture, so foldable may not be suitable. You may have to have a multi-piece backup. So there are a lot of logistic issues as well, and difficulties in calculating the IOL power, because in open globe, you will not be able to assess the axil length. You will take the IOL power from the other eye, which may not be absolutely accurate for this eye. Hence, as much as possible, if possible, you can just do an AC wash and remove the lens matter from the anterior chamber, and do a second stage cataract surgery with an IOL implantation, which will give a better outcome. But we can have sir's opinion as well.
No, you are perfect. You highlighted the important points. Like what I feel, as you said, how much is the extent to which your capsule is damaged, and how much lens matter is there in AC. So if a lens matter is there and it's touching endothelium, then there is no doubt you have to take out the lens in the same setting. The second is presence of vitreous. If there is vitreous in antechamber, again it's better to do a lens aspiration, do a good vitrectomy, because if you leave it like that, then that will keep on causing traction. So you can leave the patient aphakic because if you are not sure about the IL power calculation. But whenever there is a breach, there is vitreous and lens matter is too much that can touch your endothelium, you'll have to remove it. If you are sure that the rupture is small and you are sure that there is no breach in posterior capsule, and there is no risk of endothelial damage. In those cases, it's better to wait because that will give a better planning of the surgery. And in fact, you can put the IOL in the bag, because if you do a primary lens aspiration, even if you are leaving a bag intact, the second setting which you are going to do, you will put the IOL in the sulcus. So it's always better to wait and watch if the factors favors you, so that you can put the IOL in the bag in subsequent settings. But if you are not sure and if you feel that yes, the harm will be more compared to putting an iron in the bag, it's better to remove the lens matter whenever you are in doubt. So that's a very pertinent point which Dr. Pranita highlighted. And yes, that part we have covered, and about the complicated cases like PATS. Whenever you're dealing with such cases, always keep glue BCL ready in your OR, because at times you may not have a patch graft and there may be some tissue loss, and you don't have anything other than glue BCL to seal the tissue loss area with suturing all around. So glue BCL you should always keep in your OR when you're operating such patients. And medical legal case, Dr. Punitha has already highlighted, that is very important nowadays. And Dr. Punitha, when suppose a poor patient has come and it's a medical legal case. So, do you have anything to tell the students that how to approach such cases, and what are the most important part that must be there in the file, so that that will save them in future litigations?
So if there is any patient of trauma and the history suggests of any assault or any fight, first is they should have an MLC number, because the police needs to be informed that such an incident has happened, and filing an MLC before going on to operating this patient or before admitting will always keep you on a safe side. While if you operate and later on file an MLC, it always makes the patient side and your side on the weaker end. So try and file an MLC, ask the patient to file an MLC first. Second, on the file, documentation of your vision, PL, PR, finding the anterior segment finding, injuries onto the face, and if there are any polytrauma, do send a referral to the physician or the orthopedician. Like we have a trauma center, so we do send a consult to the trauma center, wherein they do a detailed workup and NCCT head and orbit to rule out any other fractures, because fractures, if there are any fractures, that again goes into a grievous injury. So preoperatively having an X-ray of the face is something which is absolutely basic to rule out fractures of the face and injuries onto the face that is causing a disfigurement of the face. That again goes into a grievous injury. So any injuries or lacerations of the face, that needs to be documented in your file. And obviously, the extent of injury in your eye or the corneal or scleral perf, you're obviously going to document. And any permanent privation of vision, as you all know, again goes into a grievous hurt. So, and if you're not able to see the fundus, doing a preoperative ultrasound to document if there's any retinal detachment or a foreign body is something mandatory. So, I think vision, eye trauma, facial trauma, X-ray, ultrasound, and a prior MLC. These are something which are absolutely basic that should be there in your file, and that's going to help you if there are any medical legal issues that the patient is going to deal with or you are going to deal with later on.
Thank you so much. So these are the important things that you people should remember. Proper documentation is very important. Whenever you suspect foul play, if it's for example, if patient comes to you with perforation, the history is patient says ki, no, there was no history of assault. I just got a trauma like that. If you suspect there is some foul play, then always register it as a medical legal case. That will save you in future, because the common principle of MLC is you are the expert, and if you remember your FMT knowledge, the onus is on you. For example, there is a bullet injury and somebody claims, no, I got it accidental. You're not going to buying that, right? So you have to report to the police. The patient is there and there is a bullet in the eye. Or even if the patient claims, no, this is friendly fire, accidental fire, but you have to register MLC. So always, whenever you are in doubt about the patient history or if you are suspecting any assault, it's safer side to register that as a medical legal case. And documentation, I think Dr. Pant has already told you. And remember, a common mistake that we all do, we never mention the near vision. So if you are dealing with a MLC case, perforation case, always mention the near vision of the other eye, especially if the patient is having any vitreous prolapse, uveal tissue prolapse. Why? Because risk of sympathetic ophthalmia is there. And if you haven't documented, patient develops other eye problems subsequently, then it will be a case of criminal negligence, because as a doctor, as an expert, you didn't do your proper job. You should have checked the other eyes for evidence of sympathetic ophthalmitis. So that part you should always remember and be clear about post-op course, which Dr. Panita must have told you how to manage such cases. And yes, all these trauma cases, remember, even if it's a very traumatized eye, but if you do a good job, the patient gets some ambulatory vision. So it's always important to remember the basic principles of repair, how to operate, when to operate, and proper documentation. I think if you do these three, four things, then you'll be a great trauma surgeon. Yes. Sharik, are there any more questions?
No, sir.
Okay, these are the questions few of the people they have put in the group. So I discussed these important points: length, suture distance, all these things. One thing I forgot to tell you: somebody is asking how to decide where to start. So one practical approach is rule of 50. Suppose you have put two sutures at two anatomical landmarks, then where to put the next suture? The next suture should be exactly 50% between the two sutures. Then the next is exactly 50% between the first and third. So if you follow this rule of 50, then it helps you in knowing where to put the switches, how many switches should be put. So with this, I think we conclude this session, and we are very grateful to Joja Surgical. They have supported us for this webinar series on corneal surgery learning course. And there is a short promotional video, and I request our technical team to play the video. Then we'll call it a day. Sharik, I think we are done with the videos. With
Sir,
this, we come to the conclusion of this edition of our. Yes, Dr. Anu Malika joined us. Dr. Anu, you have any comment to make? I think she's offline. So, Sharik, let's close the program here. Thank you so much, Dr. Panita Sai, for the wonderful lecture. And thank you, Sharik and AV team, for helping us. Thank you.